Bismillah ar-Rahman ar-Rahim. Today we're going to talk about the cardiology crash course. Today we're going to talk about the topic of CMR. This is a review of the CMR. We're going to talk about the major topics in cardiac MRI and what are the major indications of cardiac MRI. This is the most important thing for a cardiologist to know the major indication when to refer a patient to cardiac MRI. So this course is not for specialists in cardiac MRI. This is for the general cardiologist and physician for the indications and when to order a cardiac MRI. Okay, so the goal of CMR, why we do the CMR study, there's a clinical question from the referring physician. He wants answer for this question. Cardiac MRI study can be done, can be performed in 1 hour, 2 hours, but here we have to be focused. In 30 minutes, you need to get the answer. What is the cause of LV systolic dysfunction? Is this a constrictive pericarditis or restrictive cardiomyopathy? What is the cause of dilated cardiomyopathy? Is it myocarditis? What is the nature of this cardiac mass I have seen in echo? So there's many questions, but you have to be focused on the question, the clinical questions. Cardiac MRI is not done for research. We do it for a desired clinical question. We're not going to talk about the physics of cardiac MRI. But as you know, everything in the universe is rotating, like the planets and the Earth. Also, the atoms inside our bodies are rotating. It is called spinning, because you're going to find this term, spinning. It's always spinning, rotating. And one of these atoms is the hydrogen atom. Why we do choose the hydrogen atom? Because our body contains 80% water. Okay? When what is water? It's H2O. Have abundant trillions hydrogen atoms. Okay? Because someone may ask, why don't we image the sodium? Why don't we image the potassium? Because the hydrogen is the simplest atom in the Mendel table, right? It has one proton and one electron, so it's the easiest to be studied. Okay? And what do we study in cardiac MRI? Do we study the electron or the proton? We study the proton of the hydrogen atom that is present in water molecule in our body. So we are seeing a trillion of movement. And the hydrogen itself is always rotating. Everything is rotating. This table has atoms. It's always rotating, but we cannot see it because it's very slow. Any fluid has rotating atoms, but we cannot see it. It's different. The precision frequency is different. Okay? مش معنى ان احنا مش شايفين الحاجه يبقى هي مش موجوده. هي كل حاجه في الدنيا بتلف وكل في فلك يسبحون. كل حاجه بتلف. نتج عن هذه الحركه based on this movement ايه اللي حصل؟ This is the human body and the MRI machine. When we put, it's a 3 dimension, so we have X and Y and Z. Z is the longitudinal axis. So when we apply the radio frequency pulse, you hear the sound T, T, T. When we apply the radio frequency pulse, what happened to the proton of the hydrogen? It flips, changes its direction. This is called resonance. I apply a radio frequency RF pulse with the same frequency of this proton. So it will flip it. Only will flip the hydrogen, will not flip any other atom. Why? Because I apply it at a resonance. This is the resonance. Why? It's called رنين. Okay? كلمة رنين إن أنا بضرب ال RF pulse بنفس الفريكونسي اللي أنا عارفه بتاع الهيدروجين. طبعا الفيزيست عرفوا القصة دي. هتقول عرفنا إزاي؟ هم وصلوا. أول ما غير الاتجاه بتاعه مش هو ده الصوره اللي انا باخدها. الصوره اللي انا باخدها لما بنوقف الار اف بلس، تمام، ونستنى هيحصل ايه. انا اديت راديو فريكونسي بلس، خلاص it shift the axis of the proton. This is simply I need to reach one term في الاخر، حاجه اسمها T1 وال T2 اللي بتلخبط. اوكي، فانا هشرحها لكم في دقيقتين. انا غيرت الاتجاه بتاع البروتون. اوكي، I applied radio frequency pulse. It switched off. هيرجع كل حاجه تاني ترجع مكانها. عمليه الرجوع the return of the longitudinal magnetization رجع تاني. بيسموها البروتونز دي اتس ريلاكسنج، بترجع لطبيعتها. تمام، كل واحد بيعمل مجهود في الاخر عايز يريلاكس. فالاتومز والبروتونز wants to relax، عايزه ترجع تاني للطبيعه بتاعتها. الوقت اللي بتاخده عشان تريلاكس، تمام، سموه تايم كونستنت. قال لك لما 66% من هذه البروتونات تريلاكس ترجع تاني، حسبوا الوقت ده وسموه التايم الاولاني فيرست تايم، او سموه الفيزيست تي 1. اوكي، ده من هنا جت التي 1. والتي 2 زي ما احنا شفنا في السلايد اللي قبل ان هم كلهم بيغيروا اللونجيتيودينال بيبقى ترانسفيرس، في نفس الوقت كانوا بيحصل كوهيرنس، كلهم بيلزقوا في بعض. دلوقتي بيحصل لوس اوف كوهيرنس، بيبعدوا عن بعض. سموا الوقت ده اللي هم البروتونز تبعد عن بعض سموه التايم الثاني او تي 2. طيب ايه فايده اللي انت بتقوله تي 1 وتي 2؟ لقوا ان ربنا خلق كل تيشو موجود في جسمنا في تي 1 وتي 2 مختلفه عن الثاني. يبقى تي 1 هو longitudinal ريلاكسيشن، والتي 2 هو الترانسفيرس ريلاكسيشن. ارقام بتتحسب بالملي سكندز، خلاص، وليها كيرف معين. انتوا مش المفروض تعرفوا اي حاجه عنهم، مش المفروض تعرفوا الارقام، مش المفروض تعرفوا ايه الموضوع، ولكن ينتج عنه هذا الجدول. ايه هذا الجدول؟ انه في الراديولوجي عندنا كل المصل، كل تيشو ليه كاركترز مختلفه في التي 1 والتي 2 عن التيشو الثاني. يعني لو بصيت على الليفر غير المصل، غير السي اس اف، غير البروتينز، كل واحد ليه رقم مختلف في التي 1 والتي 2. and this is the basis of ايه الكلمه المهمه اللي لازم تقولوها في الامتحان لما تتسال: tissue characterization. what is the value of cardiac MRI؟ tissue characterization. يعني هيقول لي التيشو ده ما تصورش هو. التيشو characterization في ميكزوميتس تيشو، في فايبرس تيشو، في نيكروتيك تيشو، في ليكويد. كل الكلام ده يختلف من تيشو الى تيشو. This is the basis of tissue characterization. عشان كده لما تتسال في الامتحان what is the value بتاعت كاردياك ام ار اي، من الحاجات المهمه هو التيشو كاركترايزيشن. ما عندناش موداليتي ثانيه في الكارديولوجي بتديني بنفس القوه بتاعت الكاردياك ام ار. انتوا ده بيزكس بتاع تي 1 وتي 2. طبعا هو ليه شرح طويل ولكن مش في المجال بتاعنا. ونتج عن هذا تي 1 وتي 2 ان الفيزيست عملوا لنا حاجه اسمها سي ام ار سيكونسز. يعني لما بنيجي نشتغل في الكاردياك ام ار اي عايزين نشوف الفانكشن مثلا، فبنعمل حاجه اسمها اس اس اف بي، steady state free persistence. الاس اس اف بي ده عباره عن بالانس سيكونس. It's a mix of T2 and T1 more on T2، ولكن بيديني صور واضحه جدا. اهم حاجه فيها بتفرق عن الايكو ايه هو؟ الاندوكارديال ديلينيشن. الاندوكارديوم واضح جدا عن البلد. فلما اجي اقيس دايمنشنز انا واضح جدا انه ده السبتم بالظبط زي ما هنشوف في الحالات دلوقتي. This is the septum. I will not include paraseptal shadows، مش هدخل اي حاجه ثانيه. This is only the septum. So spatial resolution is very high. دي احد الميزات بتاعه الكارديو. طبعا I can look at the anatomy, different sequences. I can do tissue characterization. I can inject gadolinium and then wait and do late gadolinium enhancement. هيديني باترنز مختلف برضو للتايب بتاع السكار او الفايبروز زي ما هنشوف. طيب ايه اهم حاجه عايزكم تعرفوها النهارده؟ الappropriateness criteria بتاعت السي ام ار. When to refer a patient to cardiac MRI. You are seeing a patient in your clinic، عملت له اي سي جي وعملت له ايكو، and you are suspecting مثلا انه العيان ده myocarditis. So by echo you cannot reach a final diagnosis of myocarditis. Maybe it's suggestive of myocarditis. But in myocarditis, you want to see this patchy fibrosis in cardiac MRI. You want to see the myocardial edema. Okay? So each sequence has its own value in diagnosis of cardiac MRI. Appropriateness criteria, it's a multi-society. We have different society, imaging societies in the world that can put appropriateness criteria. And we're gonna discuss some cases to see what are the indications. So each case is an indication. At the end, I'll tell you what is the indication. So this is a case of 35-year-old man with recent missed anterior MRI. Okay, he went to the hospital. They did the coronary angio. They found this is the coronary angio. They found flush occlusion of the LAD, total ostial LAD. The LAD is occluded from its origin. Okay, and in echocardiography, the anterior wall is and anteroseptal are akinetic. So, would you like to do a PCI for this patient, or you want to test viability first? Since it's akinetic with total LAD occlusion, it's not an acute situation. It's a missed anterior, not a primary PCI. So this patient was sent for CMR viability. So this is one of the major indications of cardiac. And as you see here, this is called the four-chamber view, like echo exactly. You see the left ventricle, right ventricle, left atrium, right atrium. But as you see here, you can see the endocardium very clear, delineated from the blood. It's not grayish. This is black and this is white. Okay, so the arrow is the arrow is not there. Okay, so this is this is the arrow. As you see, this is left ventricle, right ventricle, left atrium, right atrium. You see the mitral valve, tricuspid valve. This is a two-chamber view. And you can see left ventricle, left atrium, and mitral valve. Actually, we learned from echocardiography the 17-segment model. So you need to know what is the name of each segment, as you see here. So if you look like this is the basal infroseptal, okay? This is the apical lateral. So you need to know this is the basal anterior, mid anterior, apical anterior. You need to know the name of the segments. And as you see here, it looks like there's an akinesia in the anterior wall. And this is the viability. So what happened when we do the injected gadolinium? Wait for 7 to 10 minutes and then acquire these images. So the gadolinium will shorten, as you know, shorten the T1. And what is the meaning of shortening of T1? Everything with short T1 will appear bright. So in viability, we have a term that is called bright is dead. When we have something bright, that this is the scar. So what you see bright here is the scar. And what you see here, actually, this scar is taking in the two-chamber view, taking the basal anterior, mid-anterior, and the apical anterior, and the apex. So the other pattern is you have to decide whether this is a transmural scar or subendocardial scar. These are the two patterns that we encounter in ischemic heart disease. Okay, it's either transmural, taking the full thickness of the segment, or just taking part of the segment, and the rest of the segment is viable. And this is very important. Subendocardial scar, completely different from transmural scar. If you find a subendocardial scar, that means there's still a hope that this segment can revive its thickening. Okay, and this is a very important concept in cardiac MRI and cardiology. That's why we do the cardiac MRI. We do the cardiac MRI to look for any hope for the patient. It's not because we want to say to the referring physician, no, this patient don't do PCI or don't do revascularization or CABG. No, we are trying to find any viable tissue. Okay. So what you see here in the short axis, you see also a transmural scar, taking the mid-anterior and mid-anteroceptor. Okay. So, and as you know from the LAD territory, that LAD, this is the 17 segment model that you should know from echocardiography. And this is the coronary supply according to whether this segment is supplied by LAD or circumflex or RCA. You should know these data. So if you look for the LAD here, it's almost most of the segments that LAD is supplying is totally scarred, transmural scar. Okay. So would you do a PCI or revascularization for this patient? We don't think that this patient will benefit from revascularization. Okay, let's say that you are one of the supporter of electrical stabilization hypothesis. I will do PCI because PCI, even if it's completely scarred, will support the electrical stability of the myocardium. We're going to tell you that this patient is a nightmare in the cath lab. Why? Because there's an important sign here. You see these black islets within the scar, within the white tissue. It's called MVO. What is MVO? So if you have a tracing on this in the exam, this is you have to comment on these black areas. الحتت السوداء دي اللي موجوده في الابيض في النص مش في الاندوكارديوم. لو لقيتها في الاندوكارديوم تحت الاندوكارديوم دي تبقى ثرومبس. لو لقيتها في وسط السكار تبقى ايه؟ MVO, microvascular obstruction. And what is microvascular obstruction? هو المايكرو سيركوليشن في الكوروناريز كم في المية من الكوروناري سيركوليشن؟ 10%, 50%, 30%. كم؟ It's 90%. 90%. So it's more important than the epicardial arteries. Okay? So this patient has MVO, microvascular obstruction. Okay? So if you decide to do a revascularization and PCI, prepare yourself for the nightmare of no reflow in the cath lab. Okay? Right. This is the 17 segment model. As I told you, you should know this from echocardiography. And this is the supply of each segment by relevant coronary. So viability is a very important indication in such patients. So if you have a patient in the clinical exam and they are asking you, you reach the diagnosis that this patient has missed anterior MI and has the total occlusion of the corresponding vessel, you should answer that I will do viability. Okay, this is second case. 49-year-old man with recent anterior myocardial infarction. In echo, he has impaired left ventricular ejection fraction with preserved myocardial thickness. And we have also akinetic anterior and anteroseptal wall. And as you see here, this is called a free chamber or a like the parasternal lung axis in echocardiography. This is the left ventricle, left atrium, and aorta. This is mitral valve, this is aortic valve. And what you see here, there's an akinesia of the whole anteroseptal wall, right? This is akinesia. But when we say akinesia, even in echocardiography, and you have to comment this on echocardiography, but also you have to comment on not all the motion or the thickening of the segment. You have to comment on is the segment has preserved thickness or not preserved, or it is thinned out. Is it here preserved thickness or thinned out? Preserved. And at the same time, it's totally akinetic. So this is really, in echo, it's like this. In MRI, in CINI, this is the SSFP, the CINI you can say CINI SSFP. So when you have a tracing like this in the exam, you would say three-chamber view, CINI SSFP view showing blah, blah, blah. Okay, akinesia of the whole anterocipitال wall. Okay, so this is a four-chamber view, same thing. And this patient with anterior myocardial infarction, usually in anterior myocardial infarction, we see that first part to be thinned out is the apex. And the apex here has preserved thickness, preserved wall thickness. Okay, so it was for me when I was doing this case, it's a little bit strange. So we will wait for other images for tissue characterization to know what's happening in this patient. This is the short axis, and this is the most important view in cardiac MRI CINIs because as you know, cardiac MRI is what is the gold standard for measuring left ventricular and right ventricular volume, ejection fraction, and mass. Again, cardiac MRI is the gold standard. So if you want to get correct numbers, it's cardiac MRI, okay? So short axis is very helpful in this issue. We take different slices from the apex till the base, okay? And then we have to do tracings of the whole segments in the end at insystole and endostole, okay? This is the basics of how we do measure the cardiac MRI. And as you see here also, it has preserved thickness. So this is strange. And now we'll do the tissue characterization. We'll inject the gadolinium. This is the perfusion, or called first pass perfusion. And this is the late gadolinium. And this is the CINI. Look what happened when we inject the gadolinium. اللي كنا فاكرين إنه هو myocardium with preserved myocardial thickness. شايفين هنا اللون ده مختلف عن اللون ده. صح؟ اللون الابيض ده الميوكارديوم اللي حصل فيه الهيلثي اللي اخذ الجادولينيوم. قلنا الجادولينيوم بيعمل ايه؟ بيخلي لونه، بيزود السيجنال، يعني لونه يبقى ابيض يبيض. تمام؟ والاسود ده او الجراي الاسود ده مختلف بالظبط. This is a thrombus. And when we do a late gadolinium enhancement واضح الموضوع تماما. What we see here, the whitish thing is the scar. That's why it's a transmural scar. And what we see as a preserved myocardial thickness was a thrombus. So we were deceived by echocardiography and deceived even by CMR CINI. So here, tissue characterization will tell you that this is a thrombus. And this is very important. You need to give the patient what anticoagulation, right? So this is important also in doing the viability. This is the CINI, that two-chamber that we see that preserved myocardial thickness. It's not preserved myocardial thickness. It is thinned out myocardium. White line, it's the scar you see all around. And all what you see as preserved myocardial thickness is thrombus. Same thing here. You see this is a thrombus and not a preserved. And this is the white line is the scar. So viability showed us whether it's transmural or subendocardial. Very important. You have to tell the patient, or in the report, you have to report whether this transmural or subendocardial. Because subendocardial, this patient has a potential after revascularization to revive this signal. Okay? And also can show us the thrombus, also can show us the MVO, as I show you in the first. What else the viability study can show us؟ على فكرة viability ده تقريبا نص شغل الكاردياك viability. فاكرين في الباثولوجي زمان في سنة ثالثة لما كنا بنذاكر myocardial infarction كان يقول لك after myocardial infarction بيحصل ايه؟ فاتي post MI fatty replacement. الأجزاء من الميوكارديوم يحصل لها ايه؟ fatty replacement. مكفي الفايبرس تيشو فيجيب فات ويحصل ايه؟ fatty replacement. الام ار اي عنده ميزه قويه جدا ان هو يشوف الفات. ازاي؟ انا صورت اهو بالتي 1 ويتد ايمج. وعلى فكره في الامتحان مش هيقول لك دي تي 1 ولا تي 2، هتجي لك تقول لك ده تي 1 او تي 2، فما تقلقوش السؤال اللي بيتسال ازاي الفرق بين تي 1 وتي 2 بالنسبه لكم في مستواكم مش هيفرق لانه هيتقال لكم تي 1 او تي 2. لو بصينا هنا في التي 1 اهو شايفين الابيض ده؟ الابيض ده this is fat within the myocardium. We have a sequence in cardiac MRI very simple. You suspect anything is fat is always bright سواء في تي 1 او تي 2. قول له اعمل لي fat suppression او fat saturation بيسموها fat sat. What is fat sat or fat suppression? Is you suppress the fat. So what was white here will become black. So you will know that 100% this tissue is a fat. Okay? So this is one of the important advantages in cardiac MRI. So also in viability, I can look at the fatty replacement. Also, some patient has some complication, as you know, called intramyocardial hemorrhage, post-MRI. This is one of the complications. Like the mechanical complication, we عندنا complication خطيرة بتحصل في الهارت. This will increase or will worsen the prognosis. This patient has intramyocardial hemorrhage. And MRI, you cannot see this by echo and you cannot see it by nuclear, but you can see it by MRI. By another sequence called T2 star, as you see here, there's an this black area is called intramyocardial hemorrhage. Okay? So the first indication of cardiac MRI is viability. And you can look at all these things from one study. Okay? Right. Other indications of cardiac MRI. A 45-year-old man, previously healthy. 3 months ago, he started to complain of progressive shortness of breath. He did an echocardiography, and he was diagnosed as apical hypertrophic cardiomyopathy, and beta blocker was prescribed. The patient didn't improve in beta blocker. Shortness of breath is progressive and it's worsening. The patient did several echocardiography exams, and then finally one of the doctors said, okay, let's do cardiac MRI. He said cardiac MRI is recommended. I don't know why this patient is not improving while he is apical hope. So the indication here was to look why is the patient is not improving, although he is an apical hypertrophic cardiomyopathy, would usually improve on beta blockers, right? And as you see here, this is a two-chamber view. You see the left ventricle, you see the left atrial mitral valve, and actually this is the cine. That's what we start with cardiac MRI, like echo. It looks like apical hypertrophic cardiomyopathy, and this is a four-chamber view. Same thing, you see apical hookum, but you see there's a pericardial effusion and also pleural effusion, which is not common in hypertrophic cardiomyopathy, because the patient has other pathology. So here's come again the magic word tissue characterization. Remember, في الامتحان لما تتزنق tissue characterization. This is the tissue characterization. These two images are the cine, and this is the first pass perfusion, and this is the T1 with fat saturation. When we do the T1, we found that what is in the apical cavity is completely different from the muscle. What we thought this is a muscle, this is not a muscle, okay? And when we inject the gadolinium, first pass perfusion is the first images that we acquire while we are injecting live. We are injecting the gadolinium and looking at the myocardium. It's completely different from late gadolinium. Late gadolinium, you have to wait 10 minutes, okay? First pass perfusion is you are looking at the myocardium while you are injecting the gadolinium. And what you see here, the signal, the myocardium is different from the cavity, right? So we wait, as you said, 7 to 10 minutes, and this is the late gadolinium enhancement. So here it's a completely different issue. Okay, what we found here, what we thought is apical hookum, this is not an apical hypertrophic cardiomyopathy. We found a fibrosis here in the endocardium, and this is called a double V sign. You have two V's. This is one V, and this is the second V by the fibrosis. And what is inside the cavity that is not taking the gadolinium? What usually doesn't take the gadolinium is a thrombus. So what we see here is a thrombus, and this is an endocardial fibrosis taking the whole endocardium. So the diagnosis here will be shifted from apical HOCM to endomyocardial fibrosis or lobular endocarditis, according if the patient has eosinophilia. This patient doesn't have eosinophilia. So first thing to do in management, what? Stop beta block. Okay, what he's taking as the major or the standard treatment as a beta blocker, you have to stop it. You have to start immunosuppression, steroids, other immunomodulating agents. And the patient actually improves dramatically. So if this patient just will do follow-up echo for 10 years, we will not know that this is a case of endomyocardial fibrosis. Okay, so a cardiac MRI can be life-saving, like in this case. Okay, will dramatically change your diagnosis. And actually, in 20 to 25%, up to 20 or 25%, we can change the diagnosis in cardiac. Okay. Another case, a 22-year-old college student presented with presyncope, ECG show LVH, and echocardiography show a hypertrophic cardiomyopathy, a classic case of hypertrophic cardiomyopathy with asymmetrical septal hypertrophy. And we know from echo that this patient has asymmetrical septal hypertrophy. The patient has presyncope. And is presyncope one of the indicator of putting the patient on the high risk for sudden cardiac death? No, presyncope is not. Syncope is one of these major determinant of, do you put a patient with presyncope, do you put an ICD for him? No, if the patient has the criteria of, we're gonna discuss it now in the different, in the following slides. So what we do here, actually the indication was risk stratification of this HOCM patient. This patient has several areas of fibrosis. As you see here, this is area of fibrosis. What you are doing here is you are putting fibrotic area, fibrotic tissue within the healthy. So what's going to happen in the electrophysiology? Micro re-entry. So this patient is vulnerable for ventricular tachycardia. And the more that you have, as you see here, there's another area here, and this is the septum. And if you find that this patient, this is the anterior wall, you see a big bunch of mid-myocardial fibrosis in the mid-anterior wall. So this patient has many areas, several areas of fibrosis. So that's when you do a risk stratification, the highest risk stratification, those with family history of sudden cardiac death, those with syncope, multiple repetitive non-SVT, hypotension on exercise, or massive LVH. The patient doesn't have any of these criteria, our patient. But the patient with intermediate, so you have patient with LVH 25, you have patient with presyncope. Okay, so cardiac MRI will help you whether this patient is high risk or low risk or intermediate risk. So if you find fibrosis more than 15%, this is the magical number that they put. I don't know why it's 15%, but this is the number and the guidelines. It's 15%. If you have fibrosis more than 15%, so this patient is indicated for ICD. This is another case of showing how cardiac MRI can deal with infiltrative heart disease. This is a 4-chamber view and 2-chamber view. And as you see here, granulomatous, non-caseating areas of fibrosis. So this area, البطش الكبيرة دي بنشوفها في حالتين، يا إما تي بي، تمام؟ بيعملوا granulomatous، granulomas. إيه اللي بيعملوا granulomas؟ تي بي والإيه؟ والساركويد. So this patient, when you find this patient and taking the septum, especially predilection for the septum, so this is a case of cardiac sarcoidosis. So this is a spot diagnosis in cardiac MRI. When you see these, although there's other criteria for cardiac MRI for cardiac sarcoidosis, but this is the major thing when you have this in the exam. So you will say this is, how would you describe this? Four-chamber view, late gadolinium enhancement, showing multiple granulomatous non-caseating areas of fibrosis in the whole septum and here in the inferior. Okay, so you give the correct. Like another indication, 25-year-old male complaining of shortness of breath, his echo show that this is a restrictive cardiomyopathy, and we want to know the indication of the cardiac MR. This is a four-chamber view. This is a four-chamber view. As you see, left ventricle, right ventricle, left atrium, right atrium. Both ventricles are non-dilated with biatrial dilatation, and very important sign here. What is it? This is important. You see that this is the center of the heart, where the tricuspid and mitral meet together. And you look at this area where I put point. Usually we have fibers in the heart that is located longitudinally. Okay, so we have the circular, we have the radial fibers, and we have longitudinal fibers. And the heart contracts in all three directions. One of the most important things when you look at cardiac MRI here, look for longitudinal contraction. Is there a longitudinal contraction? Is there a movement in the longitudinal? If you put your pointer here, actually it's not moving. So this is like an indirect sign that you know that this is a patient of restrictive, okay? And we see here a mild concentric LVH with pleural effusion and pericardial effusion. We have some pericardial effusion and some pleural. We go directly for delayed enhancement, diffuse endocardial enhancement of the left ventricle with the left atrium. And if you look here in the four-chamber view, diffuse endocardial enhancement global. All the endocardium is enhanced with also both atria are enhanced. This is a classical sign of amyloidosis, okay? This is the short axis, as you see. You cannot see here, okay, this is a subendocardial scar of ischemia. It's not the whole territories are occluded. This is amyloidosis spot diagnosis. And there's other sign called, we do a sequence called look-looker. When we do the look-looker, but because of the time, so I cannot put all the slides, the difficulty to nullify the signal in the look-looker, okay? So the second indication, I show you several cases of unexplained LVH. So LVH is a common indication, especially when it is unexplained. And what I mean by unexplained is the clinical. It's unexplained clinically, okay? It's very important when you have LVH to measure, as I told you, in echo, easily you can measure the paraseptal shadows. In MRI, if it's the endocardial delineation of the myocardium versus the blood, you can see that this is paraseptal shadows and you don't need to measure the part of the LVH. This is another case, 27-year-old male with palpitation and drowsiness. His ECG show VT with normal echo, and the plan was to do an EP study for ablation. This is a four-chamber view showing the four chambers. But what is important before the ablation is to look for a scar or fibrosis. And what we found here is a subepicardial areas in the mid-inferior wall. So planning for the EP study, you should know where's physically the scar, if there is a scar, or if there is fibrosis, okay? So an indication in the electrophysiology field before ablation is to look for a substrate of arrhythmia. انت داخل تعمل ابليشن مش عارف هي فين، هتقعد تلسوع في كل حته؟ لا طبعا، لازم تبقى داخل متاكد انه فين هتعمل الاي بي ابليشن. طبعا لما تبقى سب ابيكارديال you will change your direction. بدل ما هتدخل من الاندوكارديوم تدخل من البريكارديوم. طبعا cardiac MRI as you know it's دلوقتي بقى it's wide bore so الكلوستروفوبيا اللي كانت زمان قلت جدا. The wide bore so the patient has more space so we encounter less claustrophobia of patients. طيب, this is a classic case of cardiac MRI indication. 47-year-old female, typical chest pain for 6 hours, ST elevation with enzymes elevated. What you're gonna do is coronary angio, it's normal. So it's a case of Minoka, okay? So most cases of Minoka will do cardiac MRI, and then this is the cardiac MRI. You see that the basal part of the myocardium is contracting while the apex and part of the mid walls are not contracting. And when you do that, the gadolinium enhancement, there is no scar. So these areas that are not well contracting has no scar, and this patient has normal coronary, so the diagnosis is exactly apical ballooning or Takotsubo. And if you give just medical treatment for this patient and do a follow-up MRI, all the segments will regain its normal motion and thickening. Okay, so and very important indication, the mimics of myocardial infarction. Mimics of myocardial infarction, like the Minoka or patient with normal coronary, although they have elevated cardiac enzymes and abnormal ECG. Another important indication for cardiac MRI that you should know is when the patient has intermediate probability or intermediate coronary lesions, or a patient like this patient, 65-year-old with crescendo angina, and the patient has cardiac MRI. We do what is called stress perfusion, like we do this nuclear stress study or stress echo or stress ECG. There is a stress model in cardiac MRI. It's called stress perfusion cardiac MRI. What we do here in the first row and above is the stress perfusion. And here's the opposite of viability. What we see in viability abnormal is white. Here in perfusion, what we see abnormal is dark or black. So that means these areas, black areas, when we inject the gadolinium, the arteries are maximally vasodilated. They cannot, after giving the adenosine to stress the heart, they cannot dilate anymore. So this area will not uptake the gadolinium, but the rest of the myocardium, which is normal, will brighten, will appear bright. So this area, black area, is ischemic. So here we are testing not viability, testing ischemia, completely different terms. You have to be aware, we have two different terms. Viability, looking for scar. Ischemia, looking for ischemic segment, significant ischemic segment of the myocardium that need revascularization. And this is the middle row, is the rest. So here, we don't give stress like adenosine. And we don't see any ischemic area. And this is the viability, of course, because we're not going to see any scar or fibrosis. And this is the coronary angio. This is a critical mid-LAD. So one of the important indication is testing for ischemia by CMR. And remember, this is different from viability. In coronary artery disease, we have ischemia, we have viability. This is the 10th case and looking for a very old indication of cardiac MRI, looking for cardiac. Okay. So this is a case of a patient with large cystic intracardiac mass. Dr. Ahmed Smail did a TEE and found this. No, it's not you. No. Right. This is a two-chamber view, and you see there's a mass, large cystic mass inside the left atrium. This is what we have by TE. And then it was referred for cardiac MRI to know the nature before going to surgery. Is this, what is the nature of this mass? And what do you think here? Is it this, the first question, Is it intracardiac or extracardiac? You see here, these two masses here. So the TEA told us that this is an intracardiac, but what we see here is that this mass is compressing actually the left atrium, not inside the left atrium, and it's mimicking like a mitral stenosis. It's compressing the left atrium from outside, okay? And you see there's a turbulence at the mitral valve, and there's a borders actually between the blood in the left atrium and the two masses. As you see here, this mass. It's really cystic mass, but it's compressing the left atrium from outside. So what we found that these are, when we do the tissue characterization, this is what we do, the whole coronary sequence in MRI to look for the mass, and it was compressing actually the pulmonary veins, because also we can look at the pulmonary veins by cardiac MRI, and this mass doesn't uptake any gadolinium. So it's not a myxoma, it's a cyst that has a high T2 weighted index. So in T2, if you have a high T2 weight, that means this is edematous, or this is a fluid. So this cystic mass has fluid, and it's compressing the left atrium from outside. And when we inject the gadolinium, it's black. There's no uptake of gadolinium. Okay, so this was either a pericardial or bronchogenic mass, bronchogenic cyst. Okay, and at surgery, it was shown to be a bronchogenic cyst. So tissue characterization is very important in cardiac masses, whether this is a myxoma, it's a cyst, it's a rhabdomyoma. These are other images of the cyst compressing the left. So cardiac masses is a major indication of cardiac MR. This is a 51-year-old patient complained of palpitation, ECG showed SVT, and the CMR was done to delineate the substrate of arrhythmia and to assess etiology of dilatation of right side of the heart. So patient has SVT and echo show dilated right side. And this is what we have in the cardiac MRI. What is the etiology? You see that this is the right side of the heart. It's really dilated by cine. And then we have we have to look by short axis, we have to look at RVOT, right to chamber, different views just to get the diagnosis. But what is important when you find a dilated right side of the heart, to do what? To measure the flow in the aorta and pulmonary, to do what is called QP-QS. So any case with dilated right side, I do first QP-QS. Measure flow in aorta and measure flow in pulmonary. And what we found, it is 2.2. What is the magic number that this is a significant shunt? 1.5. It's more than 1.5. This is a significant shunt. So here you have to stop and look for a shunt. Okay. So the reason of dilated right side is a shunt. The reason of SVT, he doesn't need ablation. He need to find what is the etiology of this dilatation. And what we found actually, there's a defect in the interatrial septum. It's a large defect, but sometimes it's difficult to find it, even by echo. That's why it was missed by echo. You need TEE to find it, because it is a sinus venosus. There was a sinus venosus ASD that, as you see here, with partial anomalous pulmonary venous rhythm. We look at by different. So another indication, we have dilated right side of the heart. Please think about a shunt. The second cause you have to think about ARVC. And the third cause you have to look for, but you have to say this in the exam. Shunt, ARVC, and tricuspid valve disease. Okay, organic tricuspid valve disease. This is a case of a dilated ventricle with patient with shortness of breath. As you see here, it's very easy diagnosis. It's a non-compaction. spongy myocardium with a non-compacted to the compacted myocardium, it's more than 2.3. Can CMR help in heart inflammation? Yes. Can look at pericarditis, myocarditis, and endocarditis. Here's a classic example of pericarditis. You see the both layer, the visceral and parietal, in T2 weighted image. And what T2? T2 is for inflammation, okay, and for edema. And as you see, these two lines in T2 weighted image is inflamed, is white, is giving high signal. So that's will tell you this patient has edematous pericardium. Okay. شايفين الخطين مرسومين رسم بتاع البريكارديوم ما بنشوفهمش كده ما بينهم في effusion. Okay. And this is the late gadolinium enhancement. You see a circumferential late gadolinium enhancement of the pericardium. So this is the pericarditis. For endocarditis, of course, the echocardiography is the hallmark and for the diagnosis. This is a mitral valve mass for vegetations. You can look at any vegetations by cardiac MRI. This is part of study in our department that we were doing for CMR and infective endocarditis. And as you see, there's a mass here in the mitral valve. This patient was admitted in our department with a mass and intermittent fever. Dr. Ahmed Mohsen did echocardiography and even 3D imaging for the mitral valve. As you see, there's a mass here in the mitral valve. Very nice delineation. Okay. This patient received antibiotics for 2 weeks without improvement. Okay. And the culture was always negative. We didn't have a causative organism. So we decided after that in the grand round to do a cardiac MRI as a part of our protocol for the infective endocarditis project by cardiac MRI. And we have an interesting findings. This is the mass on the posterior mitral leaflet. What we found when we inject the gadolinium, that the mass was uptaking gadolinium. You see this mass? See the mass? The vegetation of infective endocarditis does not uptake gadolinium, okay? So here is a mass that is uptaking a gadolinium. So this is not an infective vegetation. This is different, something else. It's either papillary fibrillostoma or a Libman sac, non-infective vegetation. And what is supporting here the Libman sac diagnosis that we see that there's a mid-myocardial enhancement. You see this whitish thing. This is myocarditis. So this patient was given a diagnosis of myocarditis, and he was found lately that this is an antiphospholipid syndrome, and this case was published, and you can look at the details of this case. So third indication in inflammatory heart disease is the myocarditis. And as you see here, again, T2 weighted image. When we see T2 weighted image, that's mean edema. You see this whitish area and the black area. This is myocardial edema. And in late gadolinium enhancement, you see the area of fibrosis here or inflammation and T2 chamber view. Also, you can see the myocarditis here in this patient with myocarditis. Classic indication, as we said, differentiate constrictive pericarditis versus restrictive cardiomyopathy. And as you see here, the pericardium is thickened, there's a septal bounce, there's a ventricular interdependence. All of these signs, it's easily diagnosed by cardiac MRI that this is a constrictive pericarditis, not a restrictive cardiomyopathy. Aortic dissection, old indication like congenital heart disease and cardiac MRI. It's good for follow-up of the patient. Of course, in the emergency, either TEE or CT will be better, but for the follow-up, cardiac MRI will be very helpful. Also, we said this patient has ventricular tachycardia with right side, dilated right side, and you see these microaneurysm in the right wall, in the RV wall. So, and as you see here, microaneurysm, and when we do the T1 weighted image and do the fat sat, there's a fatty deposition of fat saturation. We found that there's a fatty deposition in the RV wall, and even in the late gadolinium enhancement, there is fibrosis. So patient with VTAC, dilated right side, and fibrofatty infiltration. But what is important is to look for criteria of ARVC. We have new criteria, but the old criteria in 2014, you look for a regional RV akinesia, dyskinesia, or the synchronous RV contraction. There's no hypokinesia, okay? Akinesia, dyskinesia, or the synchronous RV contraction, plus one of the following: either dilated RV or impaired RV, okay? Dilated RV, index value more than 110 in male and more than 100 in female, or ejection fraction 40 or less. So this was a summary of most important indications that we encounter in our daily clinical scenarios for the cardiac MRI. I show you different examples of how cardiac MRI can change our diagnosis in the clinical situation. Okay, so you need to be oriented when you use this valuable imaging tool in your clinical practice. It's you don't need you also you don't need to send a patient that is not indicated, because sometimes patients are straightforward diagnosis and you don't need to send for cardiac MRI. So you need to know the CMR indication in your daily clinical practice. Some people say, I don't need CMR, I'm fine, I don't understand it, and I'm happy like that. Don't be from this group, because this is a malpractice. You need to know what are the indications. And some people are like in the middle. I like the CMR, but I don't know the indication. This should read more about the cardiac MRI and be more interested. So any questions?